Today, the patient is a 40-year-old male diagnosed with aortic valve stenosis. They were born with a bicuspid aortic valve rather than the ideal tricuspid valve, and it has narrowed due to calcium buildup which caused it to stiffen. This has limited the blood flow from the left ventricle to the aorta, causing the muscles around the left side of the heart to thicken. We need to replace heart valve to limit and prevent further complications. We can choose between the bioprosthetic valves or the tissue-engineered heart valves.
Bioprosthetic heart valves have been invested and in use since the 1980s. Thanks to technological advancements of our generation, I recommend the resilient, innovative Edwards Life Sciences Inspire Cecilia biological heart valve. It is made up of tissues derived from cows, and it is fixated with a special disinfectant which reduces the chance of body rejection and the buildup of calcium. Due to the long term of research invested into biological heart valves, results have shown that patients have experienced improved heart activity and durability post-operation. Valve gradient is a measure of pressure difference between either side of the valve. The higher the valve gradient, the more severe the valve disorder. Due to the design of the ELIR, it can be ideally measured in size according to the patient's heart. Data has shown that the gradient reduction is highly evident and very beneficial for patients. Furthermore, as the patient is still young, they chose this heart valve over the mechanical valve, as they stated they do not want to experience drastic lifestyle changes, such as commitment to a restricted diet, regularly taking blood thinners, and routine blood testing. Although the ELIR lasts up to 20 years, valve replacement can easily be conducted via transcatheter aortic valve replacement implantation. It is a technique that invades the body in a microscale, meaning that it can be performed under local anesthesia and a beating heart. To conclude, due to the extensive use and research and data supporting the ELIR, I see no argument that the bioprosthetic heart valve is perfect for the patient.
Native human heart valves are living dynamic tissues that grow and remodel throughout postnatal and adult life. Bioprosthetic valves are non-living. It's their main limitation. Therefore, this patient will likely have to come back for many reoperations because they've outlived this valve. However, I've got a solution. Tissue-engineered heart valves are living tissues grown from the patient's cells, mimicking all the essential hemodynamic properties of the original native valve. It works by using a scaffold coated with biochemical recruitment signals to promote cell attachment and multiplication. This can be done inside or outside the patient. With time, the scaffold is eventually replaced by newly regenerated extracellular matrix cells, or in simpler terms, the valve is regrown, just like before, with the capability to adapt and change with the body. This is a polymer-based scaffold. It's easy to synthesize and reproduce. It has minimal batch-to-batch variations, and it lacks foreign antigens that may trigger body rejection. The scaffold works like a colouring book, guiding the cells and using the immune response to grow around it and form a complete image. Once the valve is grown, the scaffold degrades and leaves behind the newly formed functional tissue. If we use this instead, the patient will have a living, long-lasting valve replacement, reducing the need for reoperations and the likelihood of outliving their bioprosthetic. This is an off-the-shelf product, reducing costs for the patient, and it can be delivered non-invasively. This is also a groundbreaking technology for children with congenital heart defects, since the valve can grow with the child and reduce lifelong complications. This is beneficial for today's patient as he is still young.
While both technologies have their advantages and disadvantages, something to consider for both is interpatient variability. For bioprosthetics, there is a risk of size inaccuracy, where the prosthetic may be either too large or too small, causing even more complications for the patient and reducing the effectiveness of the prosthetic. For engineered valves, the patient would need to be immunologically healthy and without any diseases that may impact cell growth. Otherwise, the tissue would not successfully grow in the patient. In terms of accessibility, both technologies are incredibly advanced, making it difficult for individuals in rural or economically disadvantaged regions to acquire. Bioprosthetics and engineered valves are both advantageous over traditional mechanical valves, avoiding the need for the patient to take anticoagulants or blood thinners. However, bioprosthetic valves are still prone to degradation and even calcification, increasing the likelihood of reoperations. This is essentially concerning considering the recovery times and expensive reoperation procedures pose. For engineered valves, although inexpensive, the technology hasn't been completely harnessed yet. Scientists are still fine-tuning the host's immune response. In other words, your body might not grow cells on the scaffold at all, treating it as a foreign invader and breaking it down. Even if the engineered heart valve is successful, the replacement will not have the same elasticity as the original valve. Elastic fibers are essential for the heart to reset for the next heartbeat, and these cells are generated and grown with us from birth. Although the body can regenerate those cells partly on the engineered scaffold, clinical trials have failed to show complete regeneration. This places the patient at risk of future complications that could lead to valve failure, worsening their condition.
So really what everyone's saying is mine's the better one.
No, I'm pretty sure mine's the better one.
Hey guys,